Hi, everyone. Thank you for joining us today for MVC's first sepsis work group of 2024. My name is Christy Degner, and I'm a Site Engagement Coordinator for MVC. I look forward to facilitating this work group today. Today's sepsis work group will feature a presentation by Eileen Creutz and Kelli Souheaver, who are program evaluation specialists for the Michigan Hospital Medicine Safety Consortium, otherwise known as HMS. Eileen worked as a registered nurse at Michigan Medicine's Intermediate Care Unit for 7 years prior to joining the HMS Coordinating Center. Her clinical expertise includes management of both invasive and non-invasive ventilated patients, artificial airways, pre- and post-lung transplants, and acutely ill surgical patients. Prior to her time at Michigan Medicine, Eileen worked as a lab technician at Grand Valley State University in the Department of Microbiology for 2 years. Eileen received her BSM from Grand Valley State University's School of Nursing. Kelli worked as a nurse in Michigan Medicine's Mott Children's Peri-Anesthesia Care Unit and Children's Emergency Services prior to joining the HMS Coordinating Center. Her clinical background includes OBGYN, radiology, peri-procedural care, and emergency care. Kelli obtained her BSN and MSN in Leadership, Analytics, and Innovation in Nursing from University of Michigan. Thank you, Eileen and Kelli, for being here today. Before you begin your presentation, I have a few housekeeping items to review. So first, the session is being recorded. The slides and the recording will be shared with all attendees following the work group. We will be monitoring the chat throughout the presentation, so feel free to add questions there. We'll also have some designated time at the end of Eileen and Kelli's presentation for some Q&A and discussion. Lastly, your feedback is very important to us. If you could please complete the post-work group survey in a link that will be provided in the chat and in an email sent following the work group, that would be greatly appreciated. As a reminder, for hospitals participating in MVC's component of the BCBSM P4P program who would like to receive credit for this work group, this survey is mandatory for attendance. Without further ado, I will pass it over to Eileen and Kelli. Thank you again for being here.
Awesome. Oh. All right. Well, thank you so much for having us today. I have to say, I'm so excited to see so many HMS faces on this call. For today's MVC Sepsis Work Group, Kelli and I are going to be presenting an overview of our HMS Sepsis work, and we're specifically going to focus on our new HMS Sepsis Toolkit. Next slide. You already heard a quick introduction, but this is just another slide to go through kind of our experience and background. Both Kelli and I co-lead the sepsis project here at HMS, and so we are very excited to share our work. Next slide. Today's agenda will start by going through an introduction to HMS. Oops. Sounds like we have an unmuted person. There we go. Okay, so today's agenda will start by going through an introduction to HMS and HMS sepsis. We'll review our process measures, specifically the peri-discharge measures and outcomes. We'll discuss our partnership with the CDC, and then we'll move into our sepsis toolkit review. Next slide. So we'll start with a quick introduction to HMS. Many of you are familiar with the Blue Cross Blue Shield CQI model, of which we are one. Next slide. Our official title is the Michigan Hospital Medicine Safety Consortium, but that's a bit of a mouthful, so we shorten it to HMS. And our goal here at HMS is to improve the care of a broader group of patients not generally targeted by other consortiums, and that is the hospitalized medical patient. Within HMS, we have 69 diverse hospitals that participate in our collaborative, and these hospitals are spread across the state of Michigan. And they range from large academic medical centers to small critical access hospitals. On the right is a list of the various registries HMS has launched. We started out as a VTE registry to investigate causes and outcomes of DVTs and PICCs. From there, we launched into our next two initiatives, our PICC midline registry and our antimicrobial use registry. During the onset of COVID, we rapidly launched a COVID registry to better understand and treat patients affected by COVID during 2020. And most recently, we began our journey with sepsis, which was launched to a small group of pilot sites in 2021 and was fully operationalized for all sites in 2023. Next slide. And this is our HMS Sepsis team. We're led by Dr. Hallie Prescott, a pulmonary critical care physician and leading expert in the care of patients with sepsis. Dr. Jacob McSparron and Pat Posa also serve as QI consultants and sepsis experts. Elizabeth McLaughlin is our HMS program manager, and she oversees all three of our current registries. Myself and Kelli are the sepsis quality assurance coordinators, and we work with our abstractors to ensure robust and accurate data entry. Megan Heath is our HMS sepsis statistician, and last but certainly not least is our HMS program director, Dr. Scott Flanders. Next slide. Our vision at HMS Sepsis is summed up best by Dr. Prescott, whose aim is for Michigan to be the best place in the world to get sepsis care, with coordinated and evidence-based management from presentation through post-hospital follow-up. We know that in order for that vision to become a reality, we need coordinated multidisciplinary teamwork, and that needs to be implemented at hospitals because it truly takes a team to stop sepsis. So partnering with our emergency medicine, infectious disease, antimicrobial stewardship, and critical care colleagues is essential to improving care for patients with sepsis. Next slide. So now that you know a little bit about HMS, I'm going to dive into our sepsis process measures. Next slide. So we'll start off by answering the question, how does HMS identify sepsis hospitalizations? Each site has a trained abstractor that collects data on a random sample of sepsis hospitalizations, up to 18 cases per 2-week cycle. Possibly eligible cases are pulled into a list via diagnostic coding and then reviewed for qualifying organ dysfunction based on the CDC's adult sepsis surveillance criteria. We do remove cases with surgery in the first 48 hours, patients with comfort care or hospice care orders within the first 3 hours of presentation, transfers from outside hospitals, and patients that leave against medical advice. From there, the abstractor will enter the clinical data into the organ function calculator, which will determine if the case meets organ dysfunction criteria in the first 2 days. If organ dysfunction is present, the case is eligible for abstraction. Next slide. Of the cases that are entered into the database, we assess them against various process measures that are categorized into 4 bundles: the early sepsis bundle, the additional sepsis bundle, the ICU to floor transition of care bundle, and the recovery sepsis bundle. And while we measure performance for all of these measures, the measures highlighted by the red boxes are the elements we have chosen for our 2024 pay-for-performance measures. The first pay-for-performance measure is an increase in the number of cases with an antibiotic delivered within 3 hours of arrival for cases with hypotension. And the second performance measure is an increase in the following 3 peri-discharge measures: a hospital contact provided for issues post-discharge, scheduling a PCP follow-up within 2 weeks, and post-discharge care coordination via a discharge phone call or a provider visit in 3 days of discharge. These discharge measures will be the focus of today's call, as implementation of these peri-discharge measures can provide support to patients following their sepsis hospitalizations to possibly mitigate the need for readmissions. Next slide. So let's take a look at those peri-discharge measures and the outcomes that we're seeing in our data. Next slide. This slide represents the outcomes we have seen thus far in the project, and it reflects cumulative data from the project's inception. And we can see here that in-hospital mortality is right below 13%. And that number doubles by 90 days post-discharge, indicating that many of our patients never fully recover from their sepsis event. Likewise, we see a high rate of readmissions in this cohort as well, with nearly 34% of patients readmitted within 90 days post-discharge. Next, we also look at our patient's functional recovery. So if the patient is still alive at 90 days post-discharge, our abstractors perform a follow-up call to assess the patient's recovery process, such as whether they've returned to work or required modified duties, or if they have a substantial new disability based on the World Health Organization's disability assessment scale. And here you can see how the patients have answered these. About 18% have missed more than 1 month of work. Another 18% have modified duties due to their health, and 18% have a substantial new disability. All of these results indicate that these patients are living with a new level of debility following their sepsis hospitalization, putting them in a more vulnerable state of health. Next slide. So how can we help our patients recover from their sepsis events? We've identified a number of elements that are critical to supporting our patients through discharge and beyond. And you can tell that in some of these areas, we do quite well, but in other areas, we are falling short of the mark. So as I mentioned previously, for the 2024 performance year, HMS has identified the highlighted peri-discharge measures as one of the incentivized pay-for-performance metrics sites will be evaluated on this year, with a goal to reduce readmissions, mortality, and improve patients' recovery. Next slide. So here we break down the discharge and post-discharge 2024 performance measure. The goal is that at least 65% of sepsis cases discharged to a home-like setting have at least one of the 3 discharge or post-discharge coordination of care measures. The 3 coordination of care measures can be seen to the left of the screen, and it includes the hospital contacted discharge, the PCP or specialist follow-up within 2 weeks, and lastly, the post-discharge phone call or visit with a physician within 3 days of discharge. And you can see that the collaborative-wide average for all of these are quite low. So we know that we have more work to do to support our patients in their recovery process. The graph on the right shows the distribution and performance by site, where each orange bar represents a different hospital in the collaborative. And here we see high variability in performance across sites, but tend to see systems grouped together, indicating that deficits in these areas need to be addressed by system. Next slide. All right. So you've gotten your data and you can see there's a need for improvement at your site, but where do you start? Or how do you get started? At the time of our sepsis project launch, there was no concrete guidance on how to structure or create sepsis programs to perform the necessary work that was needed for the improvements. And so seeing this, HMS partnered with the CDC to develop the core elements of sepsis programs. To create this framework around the country in to create the framework for hospitals in Michigan and around the country. Next slide. HMS worked closely with Dr. Ray Dantes at the CDC during the creation of the core elements. We met and consulted with leaders from various Michigan hospitals to incorporate their feedback and get input from a variety of hospitals, including those large academic medical centers, as well as our critical access hospitals, because the goal was really to create a framework that could be implemented at hospitals regardless of size or resource availability. At the same time, HMS began construction of the HMS Sepsis Toolkit to provide resources, tools, and references to implement and support the core elements framework. Next slide. All right, and in August of 2023, the Hospital Sepsis Program Core Elements was released, and the Journal of the American Medical Association published a viewpoint article written by Dr. Prescott, Dr. Dantes, and Pat Posa regarding their work on this project. Next slide. So what now? Now sites have the data and they have the framework to implement a sepsis program, but need the resources, tools, and references to begin the education and process changes that are required at their sites. As HMS had assisted in the creation of the core elements, we were in a unique position to have our sepsis toolkit ready to reflect the structure of the core elements, as well as our own process measures to be released around the same time the core elements was released. So in November of 2023, the HMS Sepsis Toolkit was launched to our sites. Next slide. All right. So from here, Kelli is going to start discussing our sepsis toolkit and all of the great resources that we have available here. So I will hand it off to Kelli to introduce that.
Thank you, Eileen. Some of you will be familiar with some of this content. And again, like Eileen said, there's a lot of familiar faces and names here today. So for the toolkit, we're going to go over the background and goals. So the toolkit was released in November of 2023. This toolkit is to provide hospitals with evidence and tools to support the HMS performance measures and the CDC core elements of hospital sepsis programs. HMS partnered with the CDC in the creation of the core elements as discussed. And as these elements are imperative to guiding the change in sepsis care, we wanted to create a tool to help. The toolkit was made to disseminate successful tools developed by HMS hospitals and was designed to be a living document. Resources are added and updated in real time for the most up-to-date information. Information on how to access the HMS Sepsis Toolkit is available in case you'd like to follow along. We will drop the link in chat. There are two versions of the toolkit available. So one is a PDF version, static version that's updated quarterly, and then there is the live Dropbox paper document. Both are available at this link. Let me drop that in the chat really quick. Eileen, do you think you can grab that by any chance?
Yep, you can move on. I'll drop it in.
Thank you so much. So for the toolkit's launch, we wanted to share overview of all the information available in the toolkit, including where to find resources based on the information and tools you're looking for. So today I'm going to do a brief overview of this information, but we'll mainly be focusing on a deeper dive into discharge planning and reducing hospital readmissions for our patients with sepsis. There are 8 sections in this toolkit focusing on the different areas of sepsis care. So section 1 focuses on the first 3 sections of the CDC sepsis hospital care core elements. These include hospital leadership commitment, accountability, and multi-professional expertise. This section is imperative for driving change in the sepsis care area. As you know, buy-in for time, money, and resources is key to implementing change, and this section has tools to promote buy-in from critical stakeholders for sepsis improvement in your hospital. Section 2 has tools and resources to help with creating and managing guidelines and structures to support sepsis quality and improvement. The middle section, or these orange boxes of the toolkit, align with the HMS Sepsis Initiative and performance measures. Here you can find bundle-related resources to help guide your journey. And this is the area we're going to take a deep dive into our focus today. Lastly, as with any new implementation or change, evaluation is key to assessing effectiveness and if the changes are driving bigger change at your hospital. In this last section, you will find implementation science techniques such as Plan, Do, Study, Act, which most of you might be familiar with, for assessment of those implementations and improvements. Assessment is key to long-term success of your hard work for this improvement process. So for section 1, as we just reviewed, it's leadership commitment, accountability, and multi-professional involvement. The leadership commitment refers to obtaining support from hospital leadership and identifying sepsis as a hospital priority. The accountability discussed identifying a sepsis program lead or 2 co-leads. It's important to set ambitious but achievable goals for the hospital sepsis program to track your progress that you've made and to update processes to stay current with best practices. Multi-professional involvement has tools to assemble a team with relevant expertise, experts in antimicrobial stewardship, critical care, emergency medicine, hospital medicine, infectious disease, nursing, other primary services, pharmacy, and even social work. And to ensure all facets of the team are involved and engaged, that's what this section is for. So this is important to identifying local unit, physician, and nurse champions to ensure engagement on all levels. So as I said earlier, the toolkit is quite large. So with all the information available to you, sometimes it can be hard to know where to start. In this first section, there is a hospital sepsis program self-assessment tool that you can use to give you a launching point. This is great for those of you who are starting a sepsis program and even for those of you who are assessing your current program. The tool can help identify gaps, strengths, and barriers and give strategies to improve sepsis care at your hospital. This tool is also helpful to find key areas of focus while assessing your current status. Section 2 focuses on developing institutional guidelines that have been locally adapted from national guidelines and examples for identification and management of sepsis. These guidelines should be updated regularly. Creating processes that make it easy to do the right thing will assist in adapting these guidelines. So there are examples of order sets, care pathways, and even documentation templates. There are also handoff tools to help support potential points of weakness in patient care. These tools allow for a more congruent and consistent handoff at any level. These resources are available because we know your time is precious. They're tools that are already in use and are successful at other hospitals, so you do not have to start from scratch or need to reinvent the wheel to make these changes. Section 3 really goes into supportive tools for the HMS sepsis process measure bundles that Eileen went over. This section is focused on early evaluation and treatment measures. There are sepsis identification badge buddies, infographics about antibiotic timing and urgency, guidance for rapid assessments in infectious versus non-infectious processes. There's also code sepsis policies that are available to help start or manage a code sepsis process in your hospital for rapid bedside assessment when the entire care team comes together for a quick and dedicated delivery of care in these patients that are really sick. Section 4 goes into other care practices in sepsis management. So sequencing of antibiotics, the importance of utilizing balanced solutions in the treatment of sepsis, adjunctive steroid use in persistent shock patients, as well as lung protective ventilation strategies. Section 5 of our toolkit reviews the care management transition of a patient from the ICU to the floor. The HMS measures that are included in this section are ensuring a documented need for or removal of temporary central venous catheters and urinary catheters. This section is a focus on communication of ongoing management plans for these patients as they're transitioned throughout the hospital. So things like antibiotic huddles, discussions about volume status, and the need for diuresis and delirium assessments are key to the best transitions of care possible. Here we have the ICU liberation tool from this section, which aims to liberate patients from harmful effects of an ICU stay. Post-intensive care syndrome, or also called PICS, is a condition that results in new or worsening impairments in physical, cognitive, or mental health that persists beyond the hospitalization. The longer patients are in the ICU, the more likely they are to develop PICS, and this leads to longer length of stays and readmissions. Utilization of the ICU liberation bundle from the Society of Critical Care Medicine can cut ICU readmissions in half. So next example tool is the ICU pause tool. So the American Thoracic Society developed the ICU pause tool to address barriers and gaps in care during patient transitions. Transitions from the ICU are already inherently high risk time as critical information is often lost at the time of transfer. Using a tool that creates a communication framework can prevent gaps in patient care. There's an ICU pause poster from this site that you can put up in your ICU transition areas for reminders for that framework. Section 6 is where you'll find the information you need for discharge planning and prevention of hospital readmissions. We're going to focus most of our time here. Baseline functional assessments are included in this section to better understand the needs of our patients when it's time to leave the hospital. This includes physical therapy and occupational therapy consults if needed during the hospital stay. Goals of care assessments for recovery-focused practice and discharge planning to assist with identifying needs and support systems for the patients. And finally, discharge planning. This section is imperative to your work in reducing readmissions for your patients with many resources and tools that can assist you. Strategies to achieve discharge planning measures are located in this section. This is the AHRQ Project Red, which stands for Re-Engineered Discharge. This toolkit is intended to reduce hospital readmissions for many different conditions, not just sepsis. Self-assessments in this tool can evaluate the current state of your discharge process and recovery-focused processes. There's also a how-to document for the self-assessment to walk you through this process. So there is a how-to. So why would you use the AHRQ's Red? The National Quality Forum stated that one readmission or emergency department visit was prevented for every 7.3 subjects who received the Red intervention. And that's our goal here for everybody with reducing readmissions. So I'm going to walk you through discharge planning recommendations. The key points here are what we will cover in the upcoming slides. Medication reconciliation at discharge is crucial for a smoother transition home and for a safer recovery by removing unnecessary medications. This also includes ensuring home medications are continued if still needed. We want to provide anticipatory guidance for symptom monitoring for when the patients and their families get home. This can help them to get care early, so interventions can start early. Providing hospital contact for the patient if they have issues or questions post-discharge, so that when the patients and families call, they are speaking to somebody who is familiar with their care that they received for the best follow-up. Scheduling the patient an outpatient visit with their PCP within 2 weeks prior to their departure from the hospital, which will ensure follow-up care is coordinated and available for these patients as they transition back to their home lives. Conducting post-discharge phone calls with 3 calendar days after their discharge, again, ensures continuation of care for these patients. It also provides an opportunity for the patient to ask questions and for the provider to receive a patient status update in case any additional care or evaluations are needed. But why are we focusing on these discharge planning recommendations? Our very own Dr. Stephanie Parks Taylor, the chief of the Division of Hospital Medicine at Michigan Medicine, conducted a study about her sepsis training and recovery program, also called STAR. In this study, patients from the clinical trial were assigned to one of 2 groups. One group was the usual care group with no changes to their typical sepsis care. The other group is the STAR group. This group was assigned a nursing navigator who facilitated patient contact over the course of the 30 days post-discharge for these patients. This contact included a post-discharge medication review, evaluation of new symptoms or impairments, monitoring of any comorbidities that they may have already had, and also allowing for performance of palliative care if needed. The outcomes in the STAR group included more patients followed up within 10 days of discharge. 25% more had medication reconciliation. 5 times more patients from the STAR group had depression screenings than the usual care group, and 50% more had more care alignment. So overall, patients in the STAR intervention group had a 30-day all-cause mortality or readmission rate of 28.7% versus 33.3% in the usual care group. And this is just a 30-day follow-up. So to help your hospital with these discharge planning recommendations, I'm going to show you a few tools we have available to assist or improve your current processes. We have the Ideal Discharge Planning tool from the AHRQ to assist with discharge planning instructions. This will help for more consistent discharges at your site. There are also medication reconciliation tools and processes, so you can see if your current process aligns with recommended practices, and you can see if there are additional items or assessments that should be completed or added to your current process. Another tool, we have guided action plans for patients that you can print for them during their discharge process. These guides help educate the patients on signs and symptoms to watch for, when to seek help, and what kind of help is appropriate at that time. They also teach patients about post-sepsis syndrome for information. Recovery improvement information is available with infographics about hospital discharge morbidity education. This page reviews medication monitoring, reducing risk of medical setbacks, rehabilitation information, and support programs for your patients. The next tool to provide hospital contact for issues post-discharge is Impact. A historical Blue Cross Blue Shield of Michigan CQI created a wonderful set of guides, including this one, which shows you the more transition of care elements that you include at discharge, the lower the rate of 60-day readmissions for your patients. This was done particularly in relation to individuals who were discharged to skilled nursing facilities. But the concept applies to all patients to ensure that they're receiving timely and coordinated care when they transition home. These are great resources, so you can print these out, put them in common areas for discharging teams, care management teams, just a great resource that's already been created for you. Post-discharge follow-up calls. So for these calls, there are scripts and processes to help improve continuation of care for these patients after they leave the hospital. This process helps to identify any potential needs for early interventions and earlier care if needed. And finally, the last slide for this section of the toolkit, we have the Sepsis Alliance webinars. There are many, many Sepsis Alliance webinars to choose from. These webinars have free CEs and sepsis education. Some topics include resources for post-sepsis care, discharge planning, post-sepsis syndrome for guidance in post-sepsis care. In the toolkit, you will see webinars that are recommended, including the number of CEs each webinar offers. The length of the webinar is also listed and a brief description, so you know that the webinar is most relevant to the information you're looking for before you plan an hour-long session. So here we are to section 7. This covers antimicrobial stewardship in sepsis. Best practices in antibiotic treatments are here, as well as local microbiology data to develop those recommendations. There's also tools to assist with de-escalation of antibiotics. And last but certainly not least, there's section 8, implementing, evaluating, and sustaining QI. Resources from HMS hospitals for evaluation and assessment of your sepsis program are housed here. There's feedback tools, value analysis tools, and scorecards that are available. There's information about engaging stakeholders and prioritizing interventions so that it does not have to be so overwhelming. These tools are here to help you in your journey, whether you're just starting a sepsis program or if you've had a successful program for years. Sustaining improvement is key, so long-term success tools and sustainability models are located here to ensure your hard work continues on. So in summary, the HMS Sepsis Toolkit covers the continuum of care for patients with sepsis. The HMS Sepsis Toolkit provides a wide variety of references, resources, and tools. You can find examples to best fit your organization's need and context depending on what you're looking for. And then resources for both larger hospital systems and smaller critical care access hospitals are available here as well. So go check out the HMS Toolkit. Oh, sorry, I'm flipping pages. Please send us any feedback or new or updated resources on the email that's listed here. If you're reviewing the toolkit, since it is a living document, we can add new or updated resources real time. We welcome any feedback to improve the tool for everyone, so please feel free to contact us. I check this email daily, so any feedback would be great. And then we would like you all to join us for the Sepsis Alliance webinar on Thursday, February 1st from 2 to 3:30. You can use this QR code here to register. There's also a link within the register here that you'll get within the slides. So at the beginning of each new year, Sepsis Alliance identifies an influential program to highlight and share with their members. For 2024, HMS Sepsis has been invited to share ongoing work within the state of Michigan. So the webinar will introduce the viewers to HMS Sepsis, and include a panel session with the following members: Dr. Scott Flanders, which is our program director, Dr. Hallie Prescott, which is our sepsis physician champion, Pat Poza, who is a sepsis QI expert, Dr. Amy McKenzie, who's the Vice President of Clinical Partnerships and Associate Chief Medical Officer at Blue Cross Blue Shield of Michigan, and Dr. Cahill, who is one of the physician champions for Henry Ford Macomb. I will leave this up for a little bit in case you would like to use the QR code while it's here. This is the end of our presentation, so I'll show you my little hands up. Do we have any questions?
Thank you so much, Kelly and Eileen. What questions do we have today?
If you want to give our other participants a chance to ask questions, but I have one that I've been thinking about since Eileen was talking. about when you shared the graph and you mentioned that you're seeing sort of the systems grouped together. And my question is more from an implementation standpoint, particularly thinking about those sites maybe that aren't part of a system and where do they fall into that?
Yeah, into the distribution of
Yeah,
performance for that
yeah.
measure. It's really a wide variety. Some sites, especially our smaller sites, have a little bit of an easier time to make changes to their discharge summary or their AVS because they have a little bit more of an intimate relationship with the people that work there since they're smaller sites. Some of the larger independent sites run into the same problems that systems run into. It's just a little bit harder when you work for such a large area to get these changes implemented. So starting early and really utilizing your partners in this. So care management is big. They oftentimes work with you hands-on to make sure that these continuation of care goals are met, but really starting the conversation early because anyone who's worked with trying to get something changed in Epic or Cerner knows you don't get that ticket in with a lot of time for them to work on it, it takes a long time. So my biggest suggestion is starting the process early. And then if you have questions about sites that do really well in some of these areas, HMS is happy to partner you up so that you guys can talk about what other sites have done to implement these changes so that you don't have to start from square one.
Great, thank you.
Eileen, this is Erin. I'm from the MVC Coordinating Center. My question is kind of similar to Jessica's, but a little different. And Eileen, you kind of touched on it, but are there other kind of things that you think are really helpful from a site perspective in terms of implementation and successful implementation? Have you seen like specific tips and tricks that have worked really well for groups as they're implementing the toolkit?
I think doing an analysis of what is already available. Sometimes you guys have great systems set up, but it just hasn't made its way into the discharge paperwork for the patient to be aware that they exist. I have sites that have PCP discharge clinics where patients who don't have a PCP can be scheduled to go see this discharge clinic so that the continuation of care is occurring. We have sites that do have a process in place that the patient wants to call the operator to get back in touch with their physician, but there's no number for the patient on their AVS. So oftentimes hospitals are doing some of this work. It's just not being communicated with the patients. So doing an assessment of what is already available at your hospital can help as well. So you know you don't have to start from square one. And like I said, care management is typically going to be a really good place to start because they are oftentimes aware of all of those resources that are available.
Great, thank you.
Does anyone on the call have any other questions for Kelli or Eileen? I'm curious, and I have a question for everyone on the call. Could anyone share how you've used this toolkit so far, or any of the resources in the toolkit if you're familiar with them? And if you haven't used them yet, after this call, can you share a little bit about how you plan to use them? If you'd like, you can respond in the chat as well.
Yeah, we'd love to hear this too, because we are always looking at what is most useful to our users or any gaps that we might have as well. I did see someone did ask for the HMS Sepsis Toolkit email, and I dropped that in the chat. They said that they had some resources at their site. If you have site resources, we love Michigan hospital examples. So if you have some, please send those to us. We are really excited to put those in. So yeah.
I'm from McClare Macomb. We used some of the things in the toolkit as far as like discharge resources and patient information. And we actually use them as printouts for our patients.
Awesome. Thanks for letting us know. Yeah, we really tried to bulk up that discharge section because that's like what everyone wants to work on, especially readmissions are being such a hot topic and people really trying to improve that. The discharge processes are really the first place to start to prevent some unnecessary readmissions.
And thank you, Irene, for your comment in the chat. Irene said, I plan to review the toolkit and see how it may complement our current processes.
Great, let us know.
Any other thoughts? Would anyone else like to share? Okay, wonderful. Well, as Eileen and Kelly said, any feedback is appreciated to them. Looks like we have one. Thank you, Rochelle. We are trying to find discharge planning techniques that don't burden nursing and providers. Eileen and Kelly, do you have any thoughts on that?
Yeah, I know that's so tough right now. Everyone's being asked to wear so many different hats, and so it feels like really hard to ask them to just wear one more. The biggest thing I can say is if you're struggling with that, feel free to reach out to us and we can query our sites to see what other sites have done maybe so that they are implementing these practices, but not burdening these already overburdened professionals. Sometimes it's as simple as like I think it was Kim from McLaren Macomb said like doing some educational handouts can really be helpful too. So if you would like ideas on what other sites are doing, that is something that we are able to query our other sites to implement.
So Rochelle responded and said, excellent. I would appreciate that care management patient experience. Looks like we also have a message from Joy in the chat. Is there any information that is available for education in outpatient clinical settings, for example, oncology or SNF settings?
I'd have to really look back through the toolkit. If anyone's perused it lately, it's about 18 pages worth of references and information. So I'd have to take a peek to see if we included anything like that. Since our focus is really hospital-acquired sepsis, most of our resources are in regards to the hospital discharge, but we can certainly look and get back to you to see if we have any of those resources available.
Looks like we have a few other comments coming through the chat. For people who can't see the chat, I'll just read them out. From Christina, we are trying to come up with a plausible discharge plan that can be utilized system-wide. Megan, possible solution for a pilot program, having a dedicated liaison or liaisons central to discharge planning and 30 days following of comorbid patients. Julia, making actual patient appointments is a huge barrier. We give the information to the patient to contact the appropriate providers at follow-up, dates and times of appointments, who would make those calls and decide for the family patient what would work for them. Lots of issues implementing this here.
Yeah, we've had a few sites with the PCP follow-up being a big barrier for them. Specifically, it's the local PCPs they block their calendar so that people in the hospital can't see what's available, and so they have difficulty scheduling. We did take that feedback, and that's why for our discharge measures, we're only asking for one of those 3 processes to be implemented because we know there are pretty large barriers to doing some of these. We do encourage you to keep trying because we do really feel that it is important, but we understand that these are large barriers that systems have to overcome. We do have a few sites that are doing quite well in our PCP follow-up section, and we do have them do presentations once in a while to show how they are utilizing that and how they are doing so well in those areas. So once we reach out to those sites and we get that information, we are happy to share anything that comes from those presentations.
I'd like to just add a little bit to that actually and kind of ask Christina, who made the comment that you're trying to come up with a plausible discharge plan that could be utilized system-wide. Would you want to take this opportunity maybe to share a little bit about what barriers you have seen or if you've had any good successes with strategies to overcome those?
Sure. So I was kind of piggybacking off of the comment that was above mine. Sorry, I'm trying to roll back through. I don't want to misspeak. Basically, we're trying to come up with something that doesn't burden our nurses or our providers as well, and something that we can use as a central resource, like maybe a call center where all of our hospitals can call into one place potentially. We don't want to use something like a charge nurse on the floor that they were discharged, because of course we have staffing issues and you don't want to burden them, and then they have to look up the patient's chart and figure out which attending and then get a hold of the provider. So it could be time consuming. So it's about the easiest, coming up with the easiest way to be cohesive at every site and for us all to be doing the same thing, to try and evaluate that process from that perspective. We don't want to try one thing at one site, one at another. We kind of want to make sure that what we roll out is something that is, plausible for every site. So we're working on it, and I will take a look back through the checklist and different things that you have on the site to see if any of that will help us kind of get there.
Thanks for sharing that, Christina.
Thank you so much for everyone's comments. Does anyone have any final questions for Kelli or Eileen? Okay, wonderful. I'm going to go ahead and share my screen again and review some upcoming events that we have for MVC. Kelli and Eileen, thank you so much again for presenting. It's extremely informative, and those resources in the toolkit are extremely valuable. So I'm looking forward to looking into them a little bit more myself. So thank you again.
Thanks for having us.
Thank you.
I'm going to bring up my screen here for everyone. So like I said, I want to review a few upcoming events that we have for MVC. So upcoming in February are 2 virtual work groups. Will be focused on preoperative testing and cardiac rehab. Our preoperative testing work group will be on February 6th, and that will feature a discussion about preoperative testing approaches and updates from across the collaborative. And that discussion is going to be facilitated by the MVC Coordinating Center. The cardiac rehab work group is going to feature a presentation by Devraj Sukal, who's the co-director of MyCR and the associate director of BMC2 PCI, and will focus on lessons learned from liaison-mediated cardiac rehab referrals. As a reminder, all work groups occur virtually from 12 to 1 p.m., and please make sure you register for the work group to receive the correct Zoom meeting link. So with that, thank you again, everyone, for attending today and participating in the work group. Jessica did post the post-work group attendance survey in the chat. I also will be including the survey in a follow-up email that you should be receiving this afternoon. As a reminder, for hospitals participating in MVC's component of the BC BSM P4P program, this survey is required for attendance points. So please complete that. And for anyone else on the call, if you could just give us your feedback as well, that's always greatly appreciated. So thank you again, everyone, for being here today. Please let us know if you have any questions, and have a good rest of your day.